You know that deep dive we did a while back on subarachnoid hemorrhage?
Yeah,
Well, this episode is like the perfect follow-up, wouldn't you say?
I think so, yeah.
We're going to be tackling the European Stroke Organization guidelines on managing unruptured intracranial aneurysms.
Okay.
And we're really going to focus on distilling the key takeaways specifically for all those neurologists and neurosurgeons out there. You know, the ones on the front lines.
That's right. Trying to make those tough calls every day.
Exactly.
Yeah, so we'll be breaking down these pretty dense guidelines, actually, into 10 actionable highlights.
Oh, nice.
Perfect for, busy practitioners. Who has time to read all that, right?
Nobody. All right, so let's start with some basics. What exactly are UIAs?
Basically, think of them as abnormal dilations, bulges in the arteries of the brain.
Oh, okay. So kind of like a weak spot in the artery wall.
Yeah, exactly. And they're surprisingly common, actually. Found in about 3% of adults.
Wow, 3%. That's higher than I would have thought.
Yeah. And, with better imaging these days, we're catching them more and more often.
Makes sense.
Which leads us to this big question. Do we treat proactively?
Right.
Or do we just monitor and hope for the best?
Because, I mean, if it ruptures, that's a whole other ball game.
That's the real danger here. We're talking subarachnoid hemorrhage.
Yeah.
High mortality, high morbidity. It's a serious situation.
Absolutely. Which brings us to our first highlight from the guidelines.
Okay, let's hear it.
Rupture risk is low, but not uniform. Studies show the average one-year rupture risk is about 0.81%.
0.81%. Okay, sounds pretty low.
Right, but that's where it gets tricky. That's just the average.
The average, right. But each person's risk.
Individual risk can be totally different.
Totally. The size of the aneurysm,
Right.
shape, all these things play a role.
And I imagine some shapes are riskier than others?
Oh, absolutely. If you see those irregular protrusions, those are the ones that really make you nervous.
Ah, I see. So just because it's small doesn't mean we can ignore it.
Exactly.
And there was this one study I was reading about it. They followed UIAs for an average of 18.5 years. That's a long time.
Wow, almost 2 decades.
And guess what? Almost a third of those aneurysms, they seem stable for years, but eventually, boom, rupture.
That's a sobering thought. It really challenges the whole wait and see approach, doesn't it?
It really does. You can't just assume it's going to stay quiet forever.
Nope. And that leads us right into our second highlight.
Okay, give it to me.
Growth, red flag.
So, we're monitoring an aneurysm. Everything seems okay, but then suddenly it starts growing.
That's when alarm bells start ringing.
How much growth are we talking about?
Even a tiny increase, just 1 millimeter.
1 millimeter, that's tiny.
It is, but it's a strong predictor of impending rupture, and the risk goes up significantly.
Okay, so what's the actual risk level after we see growth?
Well, the data show a jump to a 2.9% rupture risk within 6 months of that growth.
2.9%, so it basically triples.
Yeah. And then at the 2-year mark, it climbs even higher to 6%.
6%. That's a game changer.
It is.
So what do we do then? Do we automatically switch to treatment?
Well, there's a tool we can use to help us decide.
Okay.
It's called the Triple S score.
Triple S, what's that stand for?
It factors in size, site, and shape.
Ah, okay, so all those key characteristics.
Right. And it gives us an estimate of the post-growth rupture risk.
So it helps us gauge how urgent the situation is.
Exactly. It's a way to guide those treatment decisions.
So let me ask, should we be more aggressive with our monitoring after we detect growth? To catch any further changes quickly?
That's a great question. And it's one that the guidelines, unfortunately, don't really address.
Oh, interesting. So there's no clear recommendation on that.
Not explicitly.
So that's up to the clinician to decide based on the individual patient.
Right. It highlights that, sometimes you need more than just the guidelines.
You need that clinical judgment.
Exactly. Experience, expertise, all that comes into play.
Okay, that makes sense. Now, this brings us to highlight number 3.
All right, shoot.
It's about the treatment decision itself, and it's really fascinating.
Oh.
There are actually no completed randomized controlled trials comparing treatment versus observation.
Wow, no RCTs. That's surprising.
I know, right? And they're looking at, quality of life or even hard endpoints like death or disability. Nothing.
So we don't have that gold standard evidence to tell us which path is truly better.
We don't. So how do we make these decisions then?
We basically end up comparing rupture risk to the risk of the procedure itself.
I see. So weighing the potential benefits against the potential harms.
Exactly. But both of those risks, they tend to be low.
So it's a tough call.
It is, and it makes shared decision-making with the patient even more crucial, wouldn't you say?
Absolutely. You have to present them with all the information.
The uncertainties, the
Yeah.
trade-offs.
And let them
Yeah.
be part of that decision.
It's a partnership.
Exactly. Okay, so now let's move on to the actual treatment options.
All right, let's talk treatments.
Highlight number 4 is surgery versus endovascular, no clear winner. We've got the traditional surgical clipping, right? And then we've got the newer endovascular techniques like coiling.
Right. But is one really better than the other?
That's the million-dollar question.
Yeah.
And the answer is it's not so clear-cut.
You know, it's funny. One ongoing trial, they found no significant difference in outcomes between clipping and coiling.
Really? So they're pretty much equal.
Based on that trial, yeah. And we see similar findings in observational studies.
But those aren't as reliable as RCTs, right?
Right. They have their limitations, so we have to take that with a grain of salt.
So how do we choose then, if the evidence is so murky?
You got to look at the individual patient.
Okay.
Age, sex, aneurysm features.
Comorbidities, all that good stuff.
Exactly. You got to tailor the approach to each specific case. It's not one size fits all.
Not at all. All right, so let's break down these factors a little more.
Okay.
Highlight number 5 is factors favoring surgery.
So when might we lean towards opening up the skull?
Right. When is surgery the better option?
Well, generally speaking, younger patients tend to do better with surgery.
Younger. Okay.
Males also tend to have better outcomes with surgery compared to females
Interesting.
if they're not on anticoagulants.
That makes sense.
And if the aneurysm has calcification, those are some of the things that might push you towards a surgical approach.
Okay, I'm following you. But you mentioned earlier that the location of the aneurysm matters a lot too, right?
Oh, absolutely. Location is key.
Like those posterior circulation aneurysms, the ones in the back of the brain?
Yeah.
Those are riskier, right?
Oh, much riskier. If we go in surgically, those have a much higher risk of complications.
So it's not just about the patient. It's about the aneurysm itself.
It's both. It's this whole intricate web of factors that we have to consider.
It's a puzzle.
A puzzle, exactly. You got to put all the pieces together to make the right call.
And every puzzle is different.
Every single one.
Okay, now let's flip the script. Highlight number 6 is factors favoring endovascular.
All right, so when do those minimally invasive techniques shine?
When is going in through the blood vessels the way to go?
Well, often older patients tend to do better with endovascular treatment.
Okay, older patients make sense.
Females, they tend to have better outcomes with endovascular compared to males.
Interesting. So it's the opposite of surgery.
Yeah, it's kind of the flip side. If they need to be on anticoagulation,
Okay.
and if the aneurysm has a wide neck, those are some of the things that might make you lean towards endovascular.
I see. And what about those pesky posterior circulation aneurysms? Are they still a problem with endovascular?
That's the interesting thing. They're generally safer to treat endovascularly.
Really? That's a big advantage.
It is. It's one of the areas where endovascular really shines.
But we can't forget that endovascular, it's a rapidly evolving field.
Oh, absolutely. New techniques, new devices all the time.
So staying up to date, that's crucial.
Crucial for sure. You got to know the latest and greatest to make the best decisions for your patients.
And that brings us to highlight number 7, which is all about teamwork.
Teamwork. Okay.
Multidisciplinary approach is key. The guidelines really emphasize that UIA assessment and management, it shouldn't just be one specialty.
Right.
It should involve neurosurgery, interventional neuroradiology,
Yeah.
and neurology,
It's a team effort.
all working together.
Everyone brings their expertise to the table.
And the guidelines actually recommend treatment at high-volume centers,
High-volume centers, right.
where they see a lot of these cases.
Makes sense. More experience.
Yeah, they recommend at least 100 aneurysm patients per year at the center.
100. Wow.
And the operator, the doctor doing the procedure,
Yeah.
they recommend they do at least 30 aneurysm procedures a year.
That's a lot of experience.
It is. So it's not just about finding the right specialists, it's about finding the right place,
The right team, the right environment.
where they're doing these procedures day in and day out.
Because experience matters.
It really does, especially when you're dealing with something as delicate as a brain aneurysm.
Absolutely. You want the best of the best.
Okay, so now let's switch gears a little bit and talk about those patients who we decide to monitor instead of treating right away.
Okay, the wait and see approach.
Right. Highlight number 8 is monitoring when and how. So if observation is the chosen path, what happens next?
Well, the guidelines recommend radiological monitoring.
So follow-up scans.
Exactly. But here's the catch. There's no clear consensus on how often those scans should be done.
Or for how long?
Exactly. So
Yeah.
how often, how long, it's a bit of a gray area.
That's frustrating.
It is, both for us and for the patients. We don't want to over-monitor, but we don't want to miss anything either.
Makes sense.
So to help with that, we can use that ELAP-TS score we talked about earlier.
Oh, right, to estimate the risk.
Exactly.
Right.
It helps us personalize this follow-up plans.
And what about the type of scan? Is there a preference?
Yeah, for routine monitoring, we usually prefer MRA or CTA.
MRA, CTA.
Okay, over
A.
DSA.
DSA. And why is that?
Well, DSA is more invasive,
So we try to avoid that if we can.
unless it's absolutely necessary.
Okay, that makes sense. But I imagine for patients, getting all these scans, it can be nerve-wracking.
Oh, absolutely. It's a lot of anxiety.
So how do we balance that with the need to monitor?
It's a tough balance. We have to be sensitive to their concerns,
Right.
but also emphasize why the monitoring is so important.
Open communication.
Absolutely. A good doctor-patient relationship is crucial.
Couldn't agree more. Okay, so we've covered the diagnosis, the treatment options, the monitoring.
A lot of ground covered.
Now let's talk about prevention.
Prevention, okay.
Highlight number 9 is all about lifestyle.
Lifestyle, always important.
Smoking cessation and BP control are paramount.
Two big ones.
Huge.
Mm-hmm.
And this is where, we shift from managing the aneurysm itself to managing those underlying risk factors.
You get to the root of the problem.
Exactly. And the data is clear. Quitting smoking, controlling blood pressure.
Essential for preventing the aneurysm from growing and rupturing.
Really makes a difference. And what's the target blood pressure we're aiming for?
Ideally, less than 130/80.
130/80. Okay.
It's a reminder that sometimes the simplest things, the things we can control,
Lifestyle changes.
they can have the biggest impact.
Absolutely. Which brings us to our final highlight for this part of our deep dive.
Okay, what's number 10?
Number 10 is all about medications.
Medications, all right.
And it's a bit of a head scratcher.
Oh,
Medications. More research needed.
more research needed, okay.
The guidelines, they actually advise against routinely starting aspirin or statins for UIA prevention.
Now that's interesting because we use those medications for so many other things.
I know. Heart disease, stroke prevention.
Seems like they'd be helpful here too.
You'd think so. But the evidence just isn't there yet.
The evidence, right.
They haven't been proven to be beneficial specifically for UIA prevention.
I see. So it's not that they're harmful.
Right.
It's that we don't know for sure if they help.
Exactly. So what do we do if a patient is already taking those medications for other reasons?
That's a great question. And unfortunately, the guidelines don't really address that specific scenario.
Another gray area.
Another gray area. So we have to use our best judgment.
Individualize the approach.
Exactly. Look at the patient's overall health, their other conditions, and make a decision based on all those factors.
So a lot of it comes down to that clinical judgment.
A lot of it does.
Weighing the risks and benefits.
And having those honest conversations with our patients.
Couldn't agree more.
It's fascinating how much we still don't know about UIAs.
Right.
All this research, all these guidelines, and yet there are still so many unanswered questions.
It's a reminder that medicine is constantly evolving.
It is. And we have to be open to new information, new ideas.
Always learning.
Always learning.
Well, we've covered a lot of ground in this first part of our deep dive.
We have.
And I think it's clear that managing UIAs, it's not simple.
It's complex, it's nuanced.
And it requires a lot of careful thought and consideration.
For sure. And it's not just about the aneurysm itself. It's
Right.
about the whole patient.
Their individual needs, their preferences, their fears.
It's about seeing the person behind the scan.
Well said.
Welcome back to our deep dive. We're picking up our conversation about those European Stroke Organization guidelines on unruptured intracranial aneurysms.
Okay, so we spent the first part really unpacking those 10 key highlights from the guidelines.
We did a lot of information to digest.
Yeah, for sure. But now I'm thinking, okay, great, we have these highlights, but how do they actually translate to, real-world patient care?
Right, from theory to practice.
Exactly. I mean, where do we even begin to apply all of this information? It can feel a bit overwhelming.
It definitely can. But I think if we step back and look at the bigger picture, the overarching theme here is individualization.
Individualization.
Mhm.
Okay.
Yeah, meaning these guidelines, they aren't a recipe book,
Right. It's not just step 1, step 2, step 3.
Exactly. They're more like a framework for making nuanced decisions.
Okay, that makes sense.
We can't just, automatically recommend treatment for every single aneurysm we find.
That's what I was thinking. It's not as straightforward as find aneurysm, treat aneurysm.
Nope, not at all. We have to look at the whole patient.
The whole
The
picture.
whole picture, exactly, not just what we see on the scan.
So age, sex, medical history, all that stuff.
All of it. And the characteristics of the aneurysm itself, of course, but also, and this is so crucial, the patient's values and preferences.
Their perspective.
Exactly. What matters to them? What are their goals? What are their fears?
So it really comes back to that shared decision-making, right? What we were talking about earlier.
It all ties together. It's not just about, here are your options, pick one. It's about having a real dialogue.
A conversation.
A conversation, exactly. It's about, guiding them through this complex landscape of risks and benefits.
Being honest about the uncertainties.
Oh, absolutely. Because let's be real, there are a lot of uncertainties in this field.
And we need to acknowledge that.
We do. And that brings us to another important point, something we've touched on throughout our discussion.
What's that?
We have to be honest about the limitations of the evidence we have right now.
Right, because a lot of these recommendations, they're based on observational data.
Exactly. Which, it's not as strong as data from randomized controlled trials.
So we're working with the best we have.
We are, but we have to acknowledge those gaps.
So for our listeners out there, the neurologists and neurosurgeons, what does this mean for them in their daily practice?
I think it highlights the importance of continuous learning.
Staying up to date.
Exactly. We can't just, learn something once and think we're good to go.
The field is always changing.
It is, especially in endovascular neurosurgery. Things are moving so fast.
New techniques, new devices.
All the time. So we have to keep learning, stay informed about the latest research.
Go to conferences, read journals.
All of it. Because we owe it to our patients to be knowledgeable.
To offer them the most up-to-date care.
Absolutely.
It's a good reminder that these guidelines, they're just that, guidelines.
They're a framework.
A starting point.
A starting point. But they don't replace clinical judgment.
And that individualized approach we keep talking about.
Right. It's up to us, the clinicians, to use our expertise and experience to apply these guidelines thoughtfully.
To each patient individually.
To each individual patient.
And that expertise, it's often best concentrated in those high-volume centers, like the guidelines recommend.
Yeah, the data really do show that patients treated at centers with a lot of aneurysm experience tend to have better outcomes.
Makes sense. The more you do something, the better you get at it.
Right. It's intuitive. If you're facing this diagnosis, seeking care at a place that sees a lot of these cases, that's something to think about.
Absolutely. And then there's that other point we discussed, the multidisciplinary approach.
Oh, yeah, that's huge. The guidelines strongly recommend that UIA management involve neurosurgery, interventional neuroradiology, and neurology.
All three working together.
Yeah, it's fascinating how each specialty brings something different to the table.
Neurosurgery, they have that surgical expertise.
Right.
Interventional neuroradiology, they're the masters of those minimally invasive techniques.
Mm.
And then neurology, they bring that comprehensive neurological assessment.
They see the whole neurological picture.
Exactly. So it's really a true collaboration.
It is. And I think, that collaborative spirit, it extends beyond the immediate medical team.
Oh, interesting. How so?
I think it's also about partnering with the patient.
Bringing them into the fold.
Exactly. Engaging them in the decision-making process, respecting their values and preferences.
Because at the end of the day, it's their body, their life.
It is. We're here to guide them, to offer our expertise, but ultimately it's their decision.
We've talked a lot about the technical aspects, the guidelines, the procedures, the risks and benefits.
The nuts and bolts.
Yeah. But we can't forget the human element here.
The emotional side.
Exactly.
Right.
Receiving a diagnosis of a brain aneurysm, even if it hasn't ruptured, that's scary.
It is. And people are understandably anxious.
So we need to be mindful of that anxiety.
Validate their concerns, offer support.
Be compassionate.
Absolutely. That human connection, that empathy, it's so important.
Couldn't agree more. Now, speaking of challenges, there's that whole dilemma with medications, right?
Oh, yeah. That's a tricky one. The guidelines recommend against routinely using aspirin or statins for UIA prevention.
But what about those patients who are already on those medications?
Right. For other conditions, like heart disease. That's a common scenario.
It is. And the guidelines, they don't really give us a clear answer on that.
They don't. It's another one of those gray areas.
So what do we do?
Well, we have to look at each patient individually.
Individualize the approach. There's that word again.
It keeps coming up, doesn't it? And for good reason. We have to consider their overall cardiovascular risk, the severity of their other conditions, their risk tolerance, their
So
preferences.
many factors to weigh.
So many factors. And that's what makes this field so challenging, but also so rewarding.
Yeah, I could see that.
We're constantly learning, adapting, trying to do the best we can for our patients, even when the answers aren't always clear-cut.
It's about navigating that uncertainty.
It is, and it's about remembering that even with the best medical care, we can't control everything.
Right, we've talked about lifestyle changes, but those are hard.
They are. Quitting smoking, controlling blood pressure, it's easier said than done.
It takes willpower. It takes support.
It does. And as clinicians, we need to be there for our patients, to offer that support, to help them find strategies that work for them.
It's not about lecturing them. It's about working together.
Exactly. It's a partnership.
It's about empowering patients to take control of their health.
Recognizing that they're ultimately the ones in the driver's seat.
Absolutely. So we've explored these practical implications of the guidelines for neurologists and neurosurgeons.
A lot to think about.
A lot to think about. We're back for the final part of our deep dive, and we've covered so much practical stuff about these guidelines, but now I kind of want to look ahead a little.
Yeah, look beyond the guidelines. I like it.
Right. What are the big unknowns? Like what are those questions that just keep neurologists and neurosurgeons up at night?
Oh, there's so many, but one that really fascinates me is biomarkers. Can we use biomarkers to predict rupture risk?
Biomarkers.
Yeah, right now we rely so much on, the anatomy, the size, the shape, the location, but imagine if we could analyze a patient's blood
Oh, wow.
or their cerebrospinal fluid.
And get a more personalized risk assessment.
Exactly. That's the dream, right?
Yeah, that's incredible. It's like personalized medicine for UIAs.
It is.
So what kind of biomarkers are we talking about?
Oh, researchers are looking at all sorts of things. Inflammatory markers, genetic factors. It's a whole big puzzle.
Complex puzzle.
We're still putting the pieces together, but the potential is huge,
Yeah, it's really exciting. So is this more of a long-term goal, or are we close to actually using biomarkers in clinical practice?
It's still early, to be honest. We need more research.
Yeah.
We got to validate these biomarkers, make sure they really work.
Right. See how well they actually predict rupture.
Exactly. But it's definitely something to watch. It's a field that's moving fast.
So it seems like we're always kind of in this in-between space, right?
How you mean?
Well, we want more information, but then we get more information and we're not sure what to do with it.
Oh, I know exactly what you mean. Take monitoring, for example.
Monitoring, yeah.
We know it's important, but how often should we do those scans? For how long? We don't really know.
And those scans, they can be stressful for patients?
They can, so we don't want to over-monitor, but we also don't want to miss anything. It's a tough balance.
It is. Do you think AI could help us with this?
AI, oh, absolutely. AI has so much potential here.
I was thinking, maybe AI could help us analyze those images,
Yeah.
detect those subtle changes that we might miss with the human eye.
You're exactly right. And not just for image analysis. AI could also help us with, risk prediction, treatment selection, even personalized treatment planning, based on the specific characteristics of each aneurysm.
So AI could really revolutionize the field.
It could. It really could. But even with all these advancements, even with AI, there's still that fundamental question.
Which is?
When do we actually intervene?
Oh, right.
And when is it safe to just watch and wait?
That's the big one.
It is. It's the holy grail of UIA management,
Because we don't have that definitive answer yet.
We don't. We need that large-scale, randomized, controlled trial.
Comparing treatment versus observation?
Head to head. To really tell us, once and for all, which approach is better.
But we don't have that yet.
Not yet.
So it's fascinating, right? With all this amazing technology, with AI, with all this research,
Yeah.
we're still grappling with this very basic question.
It's true. And I think it highlights that, medicine it's not just science.
Oh, interesting.
It's also art. There's this intuition that you develop, this judgment that comes from experience.
That you can't get from a textbook or a guideline.
Exactly. We can have all the data in the world, but at the end of the day, it's up to the clinician to apply that data.
To the individual patient.
To each unique person sitting in front of them.
So it's not just about what the data tells us.
It's about how we interpret that data, how we use it to make the best decisions for our patients.
It's a good reminder that, while we strive for evidence-based practice, there's still a place for the art of medicine.
There is. There always will be.
So I think that's a good place to wrap up our deep dive into these ESO guidelines.
It's been a great discussion.
It has. We've covered a lot of ground.
We have the highlights, the practical implications, the uncertainties.
And I think it's safe to say that managing UIAs, it's not easy.
It's complex. It's challenging.
But it's also incredibly rewarding.
Oh, it is. When you can help a patient through this, when you can guide them to the best possible outcome, there's nothing like it.
Couldn't agree more. So, to all our listeners out there, the neurologists, the neurosurgeons, we hope you found this deep dive informative.
And maybe even a little bit inspiring.
And as always, we want to leave you with something to think about.
All right, hit us with it.
With all these advancements on the horizon, biomarkers, AI, personalized medicine,
Yeah.
how will UIA management continue to evolve?
Big question.
Big question. Will we be able to predict rupture risk even more accurately? Will we develop even better treatments?
Even less invasive, even more effective.
Exactly. And will we, one day, be able to prevent subarachnoid hemorrhage altogether?
Wow, the ultimate goal.
That's the dream. So keep those brains buzzing, folks. Stay curious. Until next time.